Guys, very, very nice to see you. Happy Friday. I have really, really important news to share. And that important news to share is that the truth is Prof Rez is had his attention elsewhere for a little while. You missed him on a couple of Fridays. You heard he's golfing. You're like, what's going on with Prof Rez? And I will tell you, Prof Rez was secretly plotting to take over the medical education world. And the way he's planning on doing it is the following. So, mark my words. This is video number one on Prof Rez's new project. He likes to tack me on and put me first because he knows I can't help but jump into anything. But the truth is that he is spearheading this new innovative work that he is doing, and I always follow along, be it on VMR or on rlrcpsolvers.com. But before I say more, let me pass the mic to you, Prof Rez, for you to tell us the details on what this page means.
Ooh, well, first of all, thanks for sharing this. And I just love the cartoon graphic of us too. And this is actually probably the first time we've created high quality video. And the reason we decided to launch this page is we really want to just share our love for medicine beyond learners and also to the public. So it's going to be a page for anyone interested in medicine. It's going to involve a lot of storytelling and a lot of schema sharing with very high production qualities. We're not sure where we're going to take it yet. It's still a work in progress, but what we do know is we've really enjoyed like making it and like the editing and the productions. And Robbie's going to be featured as well in the near future. Ellen is telling you we can see your WhatsApp, so hide those secret messages. Oh, and Zachary just messaged you. We can see your WhatsApp.
I have no secrets, my dear friends. But
Who
now,
is Reza? You cheating on me again?
who is what? Who?
I'm just joking.
No, no, I don't know a Rizea. Um, oh gosh, Prof. Rez, I have so many reflections on that, but I think the most important one is the fact that you use we all the time. I will tell you, this is a small fraction of me, but hopefully a little bit more balanced in the future. This guy is one of the most innovative people I've ever met. But at the same time, he's gonna interrupt me, but you can't because I'm talking too fast, Prof. Rez. You can't. You can't. He's one of the kindest souls in the world. So I think. The objective truth is you have done 99.999% of the work. But I'm so excited for it and so excited to hop on with you and
But can I just say this really quickly? Like nothing I can show or discuss is
yeah.
without your imprint. So it really is our project.
See, he'll we you got it, Progress. We. Speaking of we also have our incredible CP Solvers Academy members actually dominating the stage today. 3 of 3, case presenter, scribe, and teaching points. So let me hand the mic to them to say a quick hello, starting with Zachariah and then Zachariah, scribe and teaching points. And then we'll hand the mic to our case presenter, who's, I think, presenting for first time on RLR. Take it away, team.
Hi, everyone. I'm Zachariah, medical graduate from South Africa, currently doing foundational training. Yeah, really excited to be part of this, what is going to be an epic RLR case.
Hi everyone, I'm, as we established earlier, the OG Zachariah, and I'm actually feeling a lot of relief today. And it's not because I'm done with the big exam, but actually just relief because I've been wondering, Prof. Rez isn't there every Friday, wonder what's happening, and it's just so relieved to hear that he's got some magic coming up.
Yeah, hi everyone. My name is Eugene. I'm a physician from Ghana. That's how I always come up. Yeah, and I'm excited to present this case to RL.
Prof. Rez, Eugene has shared so many incredible cases, including one that he actually shared from his car, presenting to Ravi a case that I will remember forever. So very, very excited for this hour. Thank you to Zachariah Squared for making this happen, and let's rock and roll.
Yeah, so this is a 22-year-old male who was brought to your outpatient clinic in a wheelchair by his mother, also accompanied by the father, visibly in pain. I would share my screen quickly and then show you on examination what we found when we took it from there. Can you see my screen?
Yes, we can.
Yeah. So you could take it away from here.
First of all, Eugene, so nice to meet you. I'm sorry I didn't catch any of your cases previously. And it's like so exciting that someone from Ghana is sitting, it seems, in a physician's room, if I'm not mistaken.
Well, that's my own
So
my
hopefully that was
house.
my last diagnostic error. You embody the physician so much, it's followed you home. But what we see here is, this is, first of all, we have to recognize this is a really young patient. And whenever I think of very young patients, I think of should I say this? Should I not? But
The answer is always yes, Prof. Rez.
you remember who was it? Was it Harry Hollander? I don't want to use his name in this.
Oh, you're throwing him under the bus too now.
Where he was like sex, drugs, and rock and roll. And the whole point there is just saying that, not to say older patients aren't at risk of these conditions, but a young person, really trauma, like doing exciting stuff, STIs, and also genetic syndromes that may occur. And we know that he's coming in a wheelchair. And then the question becomes, is he in a wheelchair because he can't walk and he doesn't have muscle strength to walk? Or is he in a wheelchair because it's just so painful? And that's why he can't imagine putting any more stress on his lower extremities. And it's so helpful to look at this picture because we see an abnormality. What we see is that the left leg is more swollen than the right leg. And we also see the orientation. It's almost like the right leg is relaxed, it's rotated towards the right, while the left leg is really straight and sort of, in a straight fashion and like kept there. So then the question becomes, should the left leg be more swollen than the right? And the answer is yes, slightly. But when it's noticeable, the reason slightly is because the left iliac vein goes under the right iliac artery. So in all of us, but it shouldn't really be grossly abnormal. So now the exercise becomes what can cause left lower extremity swelling. But I think that would be an injustice to this problem because it's really left lower extremity swelling plus pain. And whenever you add pain to that dimension, you can imagine something like an ischemic event, but you shouldn't go there first. The first question you should ask this patient is, did they have any trauma? So for example, is there a fractured bone there? And that's why his leg is swollen and why he's in so much discomfort. Beyond bone, you can just take an anatomical approach and think about the muscles, the nerves. The muscles can cause swelling, but I think you do have to consider vascular causes, especially if there is no trauma. And when you're having pain and swelling and it's due to a vascular cause, you're really thinking significant venous hypertension leading to arterial ischemia and pain. And I don't want to go down that thread, but the condition is known as phlegmasia ceruleum dolens, and then that can become phlegmasia alba dolens. Right now, this doesn't really look purple, but maybe it looks a little lighter. So I'd be worried for two things right now, Eugene. One is trauma, fracture, or like a muscle injury. Two would be some kind of ischemia from venous hypertension and lack of arterial blood flow. Let me just pass the mic to Rabih because I think this is so exciting because you took us right to the pivot point to see, like Rabih, you're so good at this stuff. I remember you diagnosed like rhabdo once by looking at just an image. But what are your thoughts when you see this?
Yeah, Prof. Rez, who needs a CK, right? I have nothing to add. I really don't. I think that's absolutely superb. I was trying to figure out if position was a clue, and I'm also trying to figure out, Prof. Rez, if the thigh is swollen or not. It's hard to tell with the position. But yeah, I'm thinking about all the things you're thinking of, and I don't think that the image allows clarity on distinguishing these two. So I think putting your hands on it would help a lot for sure. All right, Eugene, what do you have next?
Yeah. So I'll just move straight to the history of presenting complaint. So about a month ago, the patient began experiencing progressive bilateral lower limb swelling, initially non-pitted. In response, his family applied a topical herbal preparation and tightly bandaged both legs, which reportedly provided some slight and temporary relief. But then 9 days ago, he went to play football with his friends and he twisted his right ankle. From the report, he limped briefly just from the discomfort, but then he confirmed that there were no visible swellings at the time or bruising or deformity. They took him to a peripheral clinic and did an X-ray, which was normal. He then rested, they did ice pack compressions, and then he took some over-the-counter pain medications. After 48 hours, he noted that the pain had improved significantly and he could resume normal walking. 3 days later, after this football event, he began feeling a deep, sharp ache in his left calf while walking. He described it as a pulling or cramping pain. He also noted that he had become generally warm at the time and felt a bit nauseated. Then over the next 48 hours before presentation, his entire left leg gradually became swollen, warm, and increasingly painful, especially from the foot to the groin. He became unable to bear weight, and then they had to put him in a wheelchair and brought him to our clinic. On direct questioning, he indicates that he believes he was bitten by an insect. His mother thinks that he stepped in a sharp object. His father has a superstitious belief that the patient was cursed from school. The pain in the left leg is rated 10 out of 10. He also complains of just slight pain, 1 out of 10 in his right ankle. He has experienced mild fatigue and loss of appetite over the past month. He also mentions some fever, denies any form of traumatic event to the left leg. There is no facial puffiness, no dyspnea, no chest pain, no cough, no autopnea, no recent surgeries, and he has not gone outside his local jurisdiction, so no recent travels. In his past medical history, he has no known chronic illness. In the drug history, it contains the oral medications that he took, that's the OTC NSAIDs, and then some paracetamol for pain. They couldn't specify the specific herbal treatment that he took, and he has no allergies. In his family history, there are no significant illness, no other significant issues in the family. In the social history, he's a non-smoker, non-alcoholic, he's a university student, he doesn't use any substance. Do you want me to pause here? Do you want me to continue? I have some vitals. I could do that and then I pause.
Maybe I think you've given us plenty of to dissect here, and I think you probably would be getting this information as the vitals are being collected in real life, I hope. And so I definitely in real life would be processing this information while waiting for the vital signs, and I'm really, really worried. And I'll just share that the fact that the patient, well, maybe I'll anchor us in one very common space, which is whenever a patient comes in and points to one extremity as causing them discomfort, it's often pretty easy to make progress into putting them into one of three categories pretty quickly, rather than a specific diagnosis. And the categories are either the patient has a musculoskeletal issue, broadly ranging from a ligamentous tear to septic arthritis, a vascular issue, arterial, venous, or lymphatic, or an inflammatory issue. And here, the presence of warmth is very evocative of an inflammatory issue. And unfortunately, the inflammatory issue seems to be hectic and severe and prominent, with many layers of concern that reinforce that hypothesis. The first is that the patient is nauseous. It's very, very unusual to have nausea with extremity complaints outside traumatic fractures and infections. And it's not just any infections, it's usually very serious infections. And the seriousness of this proposed infection is further reinforced by the fact that it's from the toe to the groin. Very, very extensive. So my working hypothesis is this is not, without touching it, a regular old case of a limb issue. This is serious. And let's not forget that how the patient arrives to our care is also very powerful. Here, wheelchair independent. So for me, this has triggered alarm bells, and I'm now executing that this is the necrotizing fasciitis until proven otherwise algorithm, which we can zoom into, but I think it's also important whenever you're trying to worry about a diagnosis like this to ask yourself the why. Why would this person get nec fasc? And if you have a very good reason why this person would get necrotizing fasciitis, then your concern for this entity, even before you've proven it, would be very, very high. And so, say, for example, he was in freshwater and he was studying for his boards exam, and he learned that freshwater exposure can be associated with Shigella, necrotizing fasciitis, and there you go. So I think that's really, really key. So I'm intrigued by the why here because he's 22 and he's young, but he does have some subacute features. And the subacute feature seems to be that this 22-year-old man developed lower extremity edema for a month, and also that he had some non-specific but certainly intriguing symptoms like malaise and nausea for a month. And so I think analyzing those might give us a sense of why this patient ultimately got necrotized, or ultimately could have necrotizing fasciitis. And I'll just share with you one small nugget to keep in your back pocket. When you have a patient who has infection and has leg swelling, there's three considerations that are prioritized. The first is actually that the patient has lymphedema, and lymphedema is notorious for superinfection. The second is the possibility that the patient has a metabolic organ causing their edema, nephrotic syndrome and liver disease. And so those three possibilities commonly cross our minds when we see somebody simultaneously develop edema, but also get superimposed infections more readily than the regular old skin compromise that happens with hot pressure. So I'm really, really worried about this patient. And at the same time, intrigued as to why this thing might be happening to him. Prof, has any other thoughts cross your mind? Anything you want to add?
No, I think that's really good. I'm just curious, just so I know, the 1/12 Zachariah, what does that stand for? So I can just follow the timeline.
1 month ago. Yeah.
1 month ago. Oh, so 1/12 is like, and then what's the 12 stand for?
Like, so 1 out of 12 would represent a month.
Oh, got it. Love it too. That's really cool. Thank you so much. All right, to you, Eugene.
Okay, so I'll continue with the vitals. So on day 0, physical examination and vitals, temperature was 37.4, heart rate 98 beats per minute, respiratory rate 18 per minute, yeah, and then BP 118/74, SpO2 99% on room air. On general exams, he was alert, but he was in severe distress due to the pain. Cardio exams, the first and second heart sounds were present, they were normal, there were no murmurs. Respiratory exams was clear, breath sounds, good air entry bilaterally. Abdominal exams was abdomen soft, non-tender, no organomegaly. Neuro exams was intact, cranial nerves and limb length strength were normal. Then I come to the focal part, that's the leg. So in the extremity exams, left lower leg was greater than or swollen more than the right. It was swollen from the foot area to the groin. It was warm to touch. It was tender on palpation. The circumference difference when we tried to use a tape measure was about 5.2 cm compared to the right. That's at the mid-thigh level. Then the right lower limb, there was just some mild pitting edema limited to the dorsum of the feet. The right ankle had normal range of motion, but it was slightly tender when we dorsiflexed. There was an old healed ulcer that we noted under the left great toe, but he denied it to be associated with any recent traumatic event. There were no other ulcers on foot and no varicosities. So we gave him iron morphine, 10 milligrams stat, just to bring down the pain. We ordered some investigations. The full blood count, HB was 12.7, MCV 78, MCH 28.2, white cells was 8.3. Just slight neutrophilic predominance, that was about 70.4%. Lymphocytes were 18.3%. Platelets was 477, was high. We did ESR and CRP. ESR was 138. CRP was 25 milligrams per deciliters. I would pause here just with these labs, and then also want to hear your thoughts on what other investigations you want to request before I give us the next labs.
Let's go. Thanks, Eugene. You know, vital signs are vital, and it's like, first of all, I'm going to leave the labs for Robbie to comment on and like what he would do next as an ED provider. But I'll just comment on the exam. I think it's really helpful to have the vital signs. Like right now, at least, he's not febrile and he's normotensive. So not to minimize like what's taking place, but that is a reassuring sign. Of course, it doesn't rule out the presence of inflammation, the lack of fever, that is, because we have other findings that really strongly suggest an inflammatory process. I was really intrigued by the ulcer on that left toe, because this is a really young guy. And usually when you have ulcers in that location, the most common cause is neuropathic in origin. Particularly someone has diabetes, they can't sense their toes hitting places, they get a skin abrasion, and then they get an infection that's makes its way eventually into the bone. Other common causes of ulcers is arterial and venous, but you just wonder, in a young person with an ulcer, could they have Charcot's, and is that a setup as a gateway to ulcer and consequently an infection? But since we brought up the possibility of like vascular issues, you do wonder, is he having a decreased blood supply and now having an ulcer in that toe? Oftentimes when you have acute ischemia, it will present as blue, cold, everything is just so sudden. It's usually chronic ischemia usually presents as gangrene. So I don't know. I'm not saying this has to be ischemic in origin, but those are the two thoughts I have for the ulcer, whether it's decrease in blood flow because of just, what's happening to his vessels, or if it's neuropathic because he has undiagnosed Charcot's and he's a young individual. The right leg also having swelling is intriguing because like whatever this process is, it's not limited to that left leg. Like there's evidence that the right leg is also involved, unless the right ankle was twisted in a soccer event and is unrelated to the left. But it just makes me think that there is a systemic process, and this systemic process has led to a consequence which is showing more of an impact on the left leg. Again, I'm really curious to what his vessels are doing in that left leg, meaning is there some kind of decrease in blood flow one way or another that is causing all this? And it can't just be arterial. Like if you think about a vasculitis, it shouldn't cause swelling. There has to be venous hypertension if that hypothesis stands correct. But I'd love to pass on the mic to Robbie, both for the lab interpretation and also, I guess I would love to know from you, Robbie, like your threat of neck fash and like how you're thinking about it with this additional information.
Yeah, Prof. Rez, I think the case for this being a hectic inflammatory disease is markedly diminished. You have no objective data for this being this inflamed, except the patient's report of fever and your sensation of warmth. The white count is underwhelming, and the ESR and CRP are underwhelming. And that's not to say that they're not abnormal. They're just not abnormal in proportion. And so I think the likelihood that this is a severe necrotizing infection has plummeted significantly. And I think the question is it significant enough to avoid pursuing the next step? And I think that would be a debate in the ER about whether to pursue that next step. And that next step would be a CT scan with contrast. Traditionally, the CT scan with contrast was taught as a test that has imperfect test characteristics. But the truth is that several studies, including one out of the hospital associated with my institution, found that the negative predictive value of a CT scan was 100%. It was a small study, about 30 patients, but all patients who had a negative CT scan for necrotizing fascia, all of them went to the OR as part of the study, and none of them had it. So I think that would be the dilemma. And I think the way you would make progress on that is if you had any reasonable alternative diagnosis. And if you found an alternative diagnosis, I think you'd be less concerned about that possibility. And so I think what happened in my mind was pursuing that alternative hypothesis, I think, has to include trying to figure out the lay of the land for this patient and being even more intrigued because of the fact that young people don't get sick very often. And so a young person having a loss of appetite for 1 out of 12 months and having bilateral lower extremity edema is very, very unusual. And so what it did for me is it's like, okay, well, why is his leg swollen? And I think a very simplistic approach to bilateral lower extremity edema to complement all the ones we've talked about is to think of it in two categories. Is there one, a structural issue in the cardiovascular system? And a structural issue would be that the pump isn't working, heart failure, or the veins have insufficient valves, venous insufficiency, or there's a blockage between the two. So not in the venous valves or the heart, but actually in the intra-abdominal IVC or something like that. And then finally, the other category is not a structural issue, but actually a substance that's causing retention of fluid. And sometimes those substances are things that the patient takes, like amlodipine or gabapentin medications. But more often than not, the main culprit is aldosterone. And hyperaldosteronism from kidney disease of all varieties, or hyperaldosteronism from renal hypoperfusion from liver disease. And now I say all that because he has no substances, no clue of any substance whatsoever. He is not taking any medications that would be implicated for this. And he has no evidence of liver or renal disease. And even though we don't have his liver or renal panel, the vast majority of patients with liver disease who have lower extremity edema have some form of obvious evidence in their belly, jaundice, altered mental status, and the vast majority of patients with kidney forms of edema are hypertensive. So if we keep it simple as structure and substance, there's no hint of hyperaldosteronism in him. There's no exogenous medication. So I'm really worried about a structural issue. And so the structural issues, again, are venous insufficiency, heart, or things in between. And venous insufficiency in a 22-year-old man would be a diagnosis of exclusion, let alone the fact that it's actually breaking the one major law of venous insufficiency, which is that it shouldn't extend above the knee. And then you look at this picture that Eugene said and say, hey, could he have heart failure? Well, he's lying completely flat. So I don't know. And he's not desatting, whatnot. So now I'm starting to say, wait, hold on. I have a young man and I can't find out why he has bilateral lower extremity swelling and he's lost appetite and he has bilateral lower extremity edema and now his left is crazy swollen and very painful. Does he have a blockage of his IVC? And so here's what I would do in real life. I don't think that you can let the sun set on necrotizing fasciitis in a case like this because the morbidity is too high. So even if the thought crosses your mind, I think you should pursue it. So what he would get in my emergency room would be two things. He would go up for these two studies at the same time. CAT scan, but I would not just do a CAT scan of the left leg. I would extend it to the abdomen and pelvis for the reasons we just talked about. And for the reasons you just talked about, Prof. Rez, I think you also need to rule out that there's not just compression on the IVC, but that the compression might have resulted in a clot, which might have resulted in phlegmasia dolorans. So maybe I'm over worrying about this patient, but I think a young person should be healthy, and the fact that he's this sick has me very, very worried. So I'm really curious how that jives with you, Prof. Rez, and what you think you might do if you were taking care of him.
Well, I would do whatever Robbie tells me to do, but I think that's spot on, man, because like it's not just bilateral edema. I love the last part of what you said, that it's really left side predominant. And I think you really got to rule out a structural etiology. And yeah, and like that's brilliant to go up to the abdomen and pelvis. So like, yeah, and here's the deal. This is probably going to be a subacute to chronic process with an acute worsening. Like even if we see a clot, it's just the beginning of the journey as to why would he have that clot. But that leg is really important right now because, you know, Roy, one of the indications to go in and thrombolyse that clot or do a catheter directed or thrombectomy is pain. Like if you're symptomatic and you have a clot, you got to get IR on board. So right there with you. Let's get that abdomen pelvis. Let's put the contrast there. Let's make sure we tell the radiologist to get a good venous picture. And Eugene, please tell us that we're right.
Yeah. Okay. So yeah, I'm gonna give some of the labs that you've requested. You've requested for liver, renals, and then some scans. So I'm gonna go ahead and do that. So urea was 14.3, creatinine was 0.78, the EGFR was 149. Total protein was 38, albumin was 13.5, ALT, AST were normal, T-bill was 2.5. Electrolyte, sodium was 129, just slightly low. Potassium was 4.0, chloride was 96.1. Then we first did Doppler, arterial Dopplers, they were normal. Then we did venous Dopplers. I will just show us a picture of the venous Doppler. Can you see my screen?
Hey, Eugene, would you want this to be featured on our YouTube channel, this case, and we'll give you a shout out? Because you have such great pictures and stuff. Okay, I'll get your email later.
So glad you're up next, Prof.
We'll move on.
Oh, is it my turn? Okay, let me interpret this study. So what we see here is images, and these images have red and blue. And I'll actually take this seriously. Okay, so there's obviously Doppler here because Doppler is what gives us the color. And what you know is that we know that the artery wasn't, impaired based on the arterial study. But what we're looking for is the vein, and we're going to see if the vein is compressed or not. And I'm assuming, Eugene, but Eugene or Robbie, correct me if I'm wrong, that blue is like vein and red is artery. Is that correct, Eugene? And it seems like the vein there isn't much of a diameter to it. So I'm just wondering, is this venous compression by something? Please correct me, man. I never look at this. I'm just like throwing a stab in the dark. Oh, you're muted. Please tell me we were right.
You're on the right path. Yeah.
That's all I needed. Robbie, do you look at ultrasounds? Did you want to take a crack, add stuff to it?
Not a Prof. That's why I ran away.
Eugene, tell us, what was it exactly?
So if you look at those images, you actually can, I mean, some people have already mentioned some fantastic stuff in the page. So it's actually showing us segments of the iliac, the femoral, superficial femoral popliteal veins. And you can actually see that the popliteal veins, superficial femoral, iliac, they're all dilated. And actually, they were actually non-compressible. And there was a long segment epigenic thrombus with near total occlusion, luminal occlusion that was noted. So I don't know if the images are quite small, but I could have made it bigger so that, yeah, it would have been better.
It wouldn't have made any better of a response for me, though. Let's be clear.
Yeah. Okay, so I'm going to go on. Our working diagnosis at this point was a proximal deep vein thrombosis of the left lower limb. And we're not sure as to why this happened. So also the renal function test, liver function test that came out, especially liver function test came out with hypoalbuminemia. So we did some urinalysis. And in the urinalysis, I'll just mention them. The color was straw, appearance hazy. Protein was 3 pluses. Glucose was negative, ketones negative, blood trace, leukocytes trace, nitrite negative. We had some microscopy as well, which showed casts that was hyaline, granular, and waxy cast. We did a lipid profile. Triglycerides were slightly high, 1.72. Total cholesterol was 9.4. LDL was 6.9. HDL was 1.72. VLDL was 0.78. LDH was 312. Uric acid was 8.2 milligrams. We went on to do HIV, Hep B, Hep C. They were all negative. Also, I forgot to add that in the urine, blood was was positive, and we had red blood cells of 2 per HPF. And then we did abdominal imaging, starting with ultrasound. Both kidneys were of normal size. There was slightly increased cortical echogenicity. There were no obstruction of masses. Liver, spleen, gallbladder, pancreas, urinary bladder, and IVC were all normal. Then we also did some clotting profile. So PT was 12.8, APTT was 32.5, INR was 1.02. Then we started SC and oxaparin. We also went on to do some ANA, anti-dsDNA, CP-C4. C3 was high, C4 was also high. I would pause here for us to have our thoughts out there before I continue the case, because the last Alicot is going to review the diagnosis.
Oh, Prof. Rez, that last aliquot doesn't count. Let's hear your thoughts, please.
Oh no, man! I really want to hear you dissect this. I just want to ask Eugene a clarifying question before Robbie talks. You know, the albumin of 13, is that like the serum? Is that low in your lab?
Yeah,
Significantly low?
extremely low.
Okay, mic to you, Robbie.
Yeah, I wonder if it's Eugene, is 40 normal for you for your units? Is that close to right? Yeah, I think it's probably Prof. Rez for us. I think it's 1.3.
That's why you're the mathematician. That's why you are the mathematician.
I can't believe you're giving me any love after watching me run away when Eugene put in the ultrasound. It was a brief, just for full disclosure, it was a very brief visit to the bathroom, and I did wash my hands. Don't ask. Yeah, I think Prof. Rez, the hypoalbuminemia here is very, very powerful, and I think that it's hard not to ignore that in the context of what we've seen, which is that we've proven that albumin is being lost in the urine. And so we have the trusted triad now of lower extremity edema, hypoalbuminemia, and proteinuria, confirming the diagnosis of nephrotic syndrome. However, there's a little bit of a twist. And the twist is that the patient has red blood cells in the urine. So the question is, what does that mean? And that suggests one of two things, that either it's related or unrelated. But if it is related, it also suggests one of two things, that the patient actually has nephrotic syndrome, an overlap, or the patient has a collapsing form of nephrotic syndrome. That's called a collapsing glomerulopathy. And so I think the thrombosis is now explained by the nephrotic syndrome because of the loss of antithrombin 3 and the resultant hypercoagulability. And the location of the thrombus may be explained by the fact that the left iliac vein is very vulnerable to superimposed hypercoagulability because of the external compression of the iliac artery on that iliac vein. So, I'm Professor, maybe I can just leave it at that for now, because I'd be really curious how you're thinking of the nephrotic overlap, the hematuria and what we'd be doing next, because I think that's an interesting space to reflect on.
Absolutely. I would be my pleasure. And I just have a question for Eugene. Did you say there was 2 red blood cells per high power fill, or the urine dips?
Yeah.
That's
Yeah.
what you said. Okay. So that's interesting, because that's not many, to be honest. Like, that's still within normal limits, like under the less than 3. So Robbie, if I'm being honest, I would want to get another UA to just see if I want to incorporate the GN into that framework. But right now, like, the mind is just going towards nephrotic syndrome, and then recognizing that when you get the lower your serum albumin is, the higher risk you have of clot. And quite frankly, though, with this patient, because of the pain, I am talking to IR and vascular to see if he's a candidate for thrombolysis, because that pain, Robbie, it's got to be ischemia from venous hypertension, I would think, It's like he's having symptomatic pain and it's like an extensive clot. If I could just share one thing really quickly with everyone, and I'll be very quick here because I know Robbie's on a time. Can you guys see my screen right? Yeah, you can. So here we are on our website, and you just type in nephrotic syndrome. I mean, the website looks so good, honestly. And we have our schema here. We're still waiting for Robbie to upload the thousands of different formulations he has on nephrotic syndrome. But it just comes down to, this is why Eugene went to suspect edema. He told us hyperlipidemia, thrombosis. But the DX is edema, urine albumin greater than 3, serum albumin less than 3. And I think oftentimes it's really the biopsy that clinches the diagnosis. The exception is if you have primary membranous nephropathy, which would be phospholipase antibody receptor. But this patient was giving us clues of inflammation, Robbie, from the real get-go. So I'm really more worried for like a secondary cause right here. And if you say, hey, what can cause the GN and that nephrotic would be an MPGN. So what are we doing here? The complements are normal, but we are gonna send the HIV. We're gonna send the Hep B, the hepatitis serology, and we're probably, I don't know, like how can you get to a diagnosis without a biopsy here? Like I think you need a biopsy and let that light microscopy, electronic microscopy, and immunofluorescence categorize like where you are in this. Sorry about that. I think the next steps will be looking at the biopsy results and then having Robbie share his figure for nephrotic syndrome secondary and primary.
What you got next, Eugene?
Yeah.
Oh,
Now we're moving to day 2. We had started enoxaparin, still some morphine for the pain. It was doing better with the pain. And then we did some examination. Now the swelling had included his testicles as well. Albumin creatinine ratio was 6,850 milligrams per grams, and the 24-hour urine protein was about 4.2 grams per day. Then we did SPEP. We had some alpha-2 globulins elevation, and we consulted nephro. So nephrology had their notes. I just copied the diagnosis that they put in there, that nephrotic syndrome with a hypercoagulable complication and to do a biopsy. So they took a biopsy. A histology report came later on in day 19. Well, on day 7, we also did a thrombophilia screen. We got results of antithrombin 3 to be 49%, which was low. Protein C activity was 74%, which was normal. And protein S free antigen was 58%, which was low. Then on the day 19, the histology report said segmental sclerosis in some glomeruli, negative for immune complex deposition. Electron microscopy, podocyte food process spacement of about 80%. So we started tap prednisolone in a high dose, and our diagnosis was primary nephrotic syndrome due to FSGS complicated by extensive left proximal DVT and secondary to acquired thrombophilia. Now, this is a very old case. We were supposed to repeat a thrombophilia after some, I think 3 or 4 months, but I couldn't follow up on that to actually clinch whether it was actually acquired from the nephrotic syndrome. So that will be the final diagnosis. And what was quite interesting to me about this case was the history. And we tend to actually have that kind of bizarre presentations in my country. So what I noticed, and it's actually helped me so much in terms of like scrutinizing the history, streamlining it very well. You could see a lot of confusing bits. I didn't want to screen them out so that I'll make it quite obvious because I know there's a B&B. So I just threw it just as it came to us. You have the parents saying this, you have the boy saying that, you have some ulcer under the feet of the leg. That actually, so however we're thinking, we're also thinking just like that. We initially were thinking some cellulitis, some neck fash. We're thinking of a highly inflammatory process ongoing in the leg. At a point, people were even thinking of fractures. We had to send for the x-rays that they did in the peripheral hospital to come to actually check if this was not actually a fracture. But what was the pivot point for us was just our routine LFT. We're just doing the liver function test, and we saw hypoalbuminemia. So that was what sparked the whole trick. That okay, let's check the urine, let's do a deep vein thrombus and an arterial and venous Doppler and see what is going on there. We saw this clot, we pursued the nephrotic range, and then we were able to diagnose. I didn't follow up, but I believe that this patient went into remission. But I mean, I can follow up later and then give us the information as to how it went. So it's a B&B case, but I just like the way it started and how it progressed, and then how we're able to clinch the diagnosis and then manage. So that's a very major thing that I learned about this case. But as just a few teaching points, since we have a bit of time, nephrotic syndrome is the three things that Dr. Rabih mentioned. You need to have some edema, hypoalbuminemia, and some proteinuria, in your urine, and then you can start thinking about nephrotic syndrome. But it's a clinical syndrome. You want to first know what is the cause. There are several etiologies. In a young person, we don't provoke it. Then I've actually looked at multiple articles where thrombosis is actually a leading phenotype for people actually with nephrotic syndrome. They can develop renal vein thrombosis. Some can even develop retinal vein thrombosis. So in a young child like that, where it just has unprovoked DVT, hasn't traveled, there are no malignancies, nothing at all, you want to start thinking about what can be this. So what can be this? Nephrotic syndrome is one of the causes. And you want to now know exactly what is the cause of this nephrotic syndrome. And just like Prof. Rez said, biopsy usually brings that particular thing out. But we still had some pinpoints in the labs, like in the urine test. Although we mentioned that the RBCs were 2 per HPF, which is actually right, that it was not significantly high, but that actually brought our mind to the thought that this could be both a coexisting nephritic and nephrotic picture. Also, the fact that the BU creatinine was normal also started pointing us to either MN, FSGS, and then we now went on to do the biopsy, and then the biopsy came out with what we were looking for. So yeah, someone has just put out the phospholipase A2 receptor, but we don't have that. We don't have the facilities to do that in my country. I think we have to outsource to South Africa through Lancet, but we didn't do that for this particular patient. So yeah, this was a very interesting case for me quite a while ago, but I'm happy that I've shared that with all of us. Yeah, thank you.
Yeah, Eugene, I think you told the story like an absolute pro. And it was so nice to like be there in the clinic with you and see this leg and walk through the journey sequentially. You taught us a lot. And ultimately it's a great day for this community in this space, because you three who are involved in this may not know it, but for the longest time in CP Solver's VMR history, there was nobody represented from the continent of Africa. And today, all three of you are representing that space, and others like Glenn are here as well. So massive kudos to you, Eugene, for a really awesome case, and really a pivot point in this space to have your continent represented in every single domain here. That was really cool. Any reflections or takeaways, Prof. Rez, before we learn from Zachariah?
What you said.
Oh, what an absolutely amazing case. I'll keep it short and sweet. I think the first thing to discuss is when you see a young patient in the hospital, there's a few things you need to take note of. The first is that the range of pathology is often different. Young patients are more likely to present with genetic diseases, sometimes have risky behaviors. But I think the other thing that I really want to emphasize is young patients have an immense physiologic reserve. And in my time in the ICU, you will see patients at physiological extremes that are clinically stable until they are not. So never ever take normal vitals in a young patient who looks unwell as something that maybe it's not so serious, because they will manage to maintain that until they crash completely. The second thing is we discussed lower leg limb edema, and we classically taught the process of unilateral being structural localized causes, and systemic diseases more likely to cause bilateral leg swelling. But as we saw in this case, that's not always true. When we go down that localized route, you can look at all the structures involved in the different compartments, and the most morbid usually is a disease of the vessels, as we saw today. And then when we move on to the bilateral causes, we always look up, think about the heart, think about the liver, think about the kidney. But don't forget that if you look up at the IVC, you can have a structural cause also causing bilateral lower limb edema. Rabih then reminded us not to forget substances. We know about amlodipine being quite common, but there are other culprits like gabapentin and aldosterone. And one more thing, when we think about infections related to lower limb edema, Rabih taught us that CT has an excellent negative predictive value in ruling out necrotizing fasciitis. Lastly, with regards to nephrotic syndrome, a lot has been said already, and I won't repeat that. Just when you have a nephrotic picture, but red cells, you need to consider, is it actually related? Maybe not. But if it is, there's two reasons. Either it's a nephrotic overlap, or it's a collapsing glomerulopathy, which is classically the most severe form of focal segmental glomerulosclerosis, often associated with HIV. Rabih then Reza reminded us that the degree of hypoalbuminemia correlates with the risk of thrombosis. And that makes sense, as more protein in your urine actually will also mean that there's more antithrombin in your urine, and that's why you're hypercoagulable. And I think lastly, what I love so much about this case was that overlap between, we think this is localized, but sometimes systemic diseases can cause a localized issue as well. Have a lovely day, friends, and keep well.
It's almost like you were never away, my friend. That was absolutely superb. Thank you for such, it's always so crisp and clear. And as Prof. Rez has said before, the fact that you type so little but speak so much more is absolutely awesome. Have a great rest of your day, everyone. Thank you so much.